neurosurgeons participating here, because this year's theme that many of you all would have read also in the papers is that every minute counts. So we need to act fast. And stroke has increased by leaps and bounds. Although, and if you look at the world ranking, we are 113, and it's a bit, it's in the ranking order. Where not the top one. Top one is a small country called Kiribati, which has an incidence of around about 233 in the ranking that they have. And the lowest is actually Switzerland, which has a ranking in the ranking, and which is only incidence is only 14.9. So we are in the mid-range, if you can call it. But we are talking about the demographic dividend that we talk about. So we have to ensure that how do we keep our demographic dividend healthy, and even our aging population is increasing. How do we take care of them? So keeping that in mind, I would like to first of all introduce our panelists today. We have Dr. Vivek Gupta, Additional Director of Neurointerventional Radiology from Fortis, Mohali. We have Dr. Uday Shankar, a Senior Consultant Neurologist from Gleneagles PGS at Kengeri and Bangalore. We have Dr. Rajeev Shankar, who is the Director of Neurointerventional Radiology at Mohali facility in Mumbai. And we have Dr. Vijay Kumar, who is the Director of Neurosurgery at Kolkata Hospital, the City of Joy. So with that, I've introduced the panelists. So I'd like to start off with first with the neurologist here down south, Dr. Uday Shankar. Is that there's a lot of misconception about stroke, whether it's heart stroke, brain stroke. So for a layman who's watching this, what exactly is a stroke and how is it different from a heart attack? So if that could be explained, it'll give a lot of clarity to the common man.
A very relevant question. Greetings to everyone. Stroke is a neurological condition, sudden neurological condition, which occurs when there is a disruption of blood flow or nutrients to brain, resulting in a type of damage which may be reversible or irreversible. There are certain types of stroke which can also happen when there is a bleeding in the part of the brain. Whereas heart attack is a heart-related condition where you have sudden disruption of blood flow or nutrients to part of the heart, resulting in problems like chest pain, changes in the heart rhythm, breathing issues, and all that. So one is a sudden condition due to disruption of blood flow to brain. Another is a sudden disruption of blood flow to heart. Yeah, as it is evident, both are very crucial and important functions to the body, and obviously the outcomes will be different.
Okay, thank you. Now we'll move to the City of Joy, Dr. Vijay Kumar. We keep hearing about the golden hour. So
Yes.
because you handle so to the common man, how do you sort of explain that what is the golden hour and why it's so critical in the treatment of stroke?
Okay, so this golden hour actually got a lot of prominence in a lot of specialities in the medical field. So trauma, particularly, is also applicable, and in heart attacks, definitely. And recently, we've also kind of pushed for the people to understand what is the significance of the golden hour. Now, in the simplest explanation, Dr. Panigrahi, is that our brain cell can survive without blood or without oxygen only for about 3 minutes. So after that, progressively the brain cells are going to die. So when you have a stroke, as Dr. Uday was just explaining, one of two things normally happens in the brain, that either a blood vessel gets blocked and so there is blood not flowing into a part of the brain, or sometimes in addition to that or along with that, you can also have a hemorrhage in a part of the brain, which then also causes further deterioration in brain function by compression and pressure, and thereby reducing blood flow and oxygenation to the brain. So on both fronts, if we want to limit the amount of damage that is happening to brain and to try and keep as much of the salvageable brain cells as possible alive, the sooner we start treatment, particularly when we are looking at revascularizing a brain that has undergone a stroke where there is lack of blood flow to the brain, the sooner we can initiate this treatment, the more likely is the functional outcome going to be better, because we are able to save more intact neurons. So time, people are very familiar with the concept that time is money. But ultimately our health is actually far more important than money. And so we now have to also look at it and paraphrase that and say time is health and health is wealth. So rather than just going straight to time is money. So that is the whole concept of the golden hour, that the sooner we can initiate treatment of an ischemic brain episode, the better recovery we could expect people to have.
Thank you, Dr. Vijay. And I'd like to introduce Professor Kameshwar Prasad, who needs no introduction. In fact, he was the former professor and head of the Department of Neurology at All Institute of Medical Sciences. And a lot of the stroke pathways that people follow have emanated from under his guidance. So, it's a great honor that Fortis has him to lead our neurology specialty council. He helps us in a major way in seeing that how do we take the stroke program forward. And so I would like to just ask him to sort of give some insight into what are the earliest symptoms people should watch for in stroke, because a lot of times, as Dr. Vijay Kumar rightly mentioned, the golden eye is important, but it's important to know what are the premonitory signs, symptoms that people should understand, the layman, even a lot of times doctors also are not aware. So what are signs and symptoms of any features that you feel are very pertinent that public should know, doctors should know, and pick it up and call for help? Or over to you, sir.
Thank you so much. Thank you for your generous introduction and kind words. I must add to what Dr. Vijay Kumar said, just to complete this golden hour concept, that in every minute, in a case of large artery occlusion, there are 2 millions, to be accurate, 1.9 millions neurons, which are the nerve cells, they die every minute. And 14 billion, not million, 14 billion synapses, which are connecting one neuron from the other, they are also lost. And if you talk about fibers, which are extension from the neurons, then about 12 kilometer of fiber length is lost every minute in a patient who has large artery occlusion leading to stroke. So that emphasizes why time is brain. But your question about what are the earliest signs, I think for public as well as for professionals, when I say, I mean those doctors who are the first contact doctors for the patients. In studies after studies, including our study which we conducted in 2001, 2 factors which delay are: number one, patients not able to recognize that this is a stroke, and the second is the doctor, first contact doctor. He keeps patient for hours because perhaps he also doesn't know what is the necessity to refer quickly. So yes, they must recognize. How will they recognize? So to facilitate public to be able to recognize, there are mnemonics which are created and acronyms, I should say. One of them is Be Fast. So Be Fast, if they remember, they will probably be able to recognize. What does Be Fast stand for? B is for balance. E is for eye. Eye means vision. F is for face. A is for arm. And S is for speech. So if suddenly somebody's balance is disturbed, not able to walk, or is getting difficulty in walking. Suddenly, somebody's vision is gone. One eye he cannot see, but then after 5 minutes is able to see, or may not be able to see, or both eyes may be getting affected. And somebody whose face is drooping on one side, so causing asymmetry. Arm is weak or may not be able to use it, or is numb, or speech is affected, which is slurring of his speech or inability to speak. So any one of these happening, then T comes, that is time to act. That is when you remember time is brain and time to act. That's the mnemonic or acronym which people use for in English. In Hindi, we say हाथ पैर बोल चाल देखना और दिखना. When we made national guidelines, on the website you will see there was this statement or phrase also, हाथ पैर बोल चाल देखना और दिखना. हाथ और पैर में अचानक कमजोरी हो जाए या सुन्नापन हो जाए, बोलने में दिक्कत हो जाए और या चलने में दिक्कत हो जाए, और देखने में दिक्कत हो या दिखने में फेस आपका टेढ़ा दिख रहा है, तो any one of these happening suddenly, whether they improve or they deteriorate, if they occur suddenly, one should think that it may be a symptom of stroke and rush to a place like a stroke-ready hospital. And I must say proudly that all Fortis hospitals are stroke-ready. So if you are close to Fortis, rush to Fortis hospital.
Thank you, sir. Now going to Mumbai, Dr. Rajeev, who is at a higher risk for having a stroke?
So, good afternoon, everyone. Firstly, on this occasion of World Stroke Day, the awareness of stroke, like Sir was saying just now, is something that really needs to percolate down to every level, at the community level, for the lay public, at the professional level, etc. Because this question you just asked about who is at a higher risk of stroke, the good, if I can say good thing about some of these diseases is that they are modifiable risk factors which are common to many diseases. For example, diabetics, hypertensives, smokers, those who lead an unhealthy lifestyle with lots of junk food or sodas, all these are common risk factors to either getting a heart attack or having a stroke. Because in the end, if you look at these organs, I always call them as, these are like fruits at the end of a rich vascular tree. If your vascular tree is healthy, your fruits are going to be well nourished and are going to be healthy. The problem occurs because this kind of atherosclerotic disease that we see, which occurs either in the coronaries in the heart or in the arteries which lead to the brain or within the brain itself, the risk factors for these are like those which we commonly enumerated, which also leads us to the answers that if we can control some of them, then we will be doing everyone a big favor by preventing these deadly diseases from occurring.
Thank you, Rajeev. Moving over to now to Mohali, Vivek. So there's a misconception that this is predominantly and only happens in elderly, but just for the common man to, and even the public who are on the podcast, is that can strokes happen in young people, or is it only an old age problem?
So, good afternoon, everyone. So, as you rightly said, it's a misconception that it's an age-related disease or it happens only to old people. If we look at the data, the earlier data this conception was partly right, because the earlier data says that it happens more frequently in more than 50 years of age group. So that is why people believe that it's a disease of an old group. But if we see the current data, especially for the last decade or 15 years, we have noticed that even people between the age group of 30 to 50, they are having stroke. And it is not less, it is to the tune of almost 20 to 25% of all stroke patients fall into this age group. So because of this, and we already know that children are also not immune to stroke, although the reasons for children having strokes are different. So if we consider all these three age groups, children, people between 30 to 50 and more than 50, so we can very comfortably say that stroke does not spare any age group. But yes, it's true that the most frequent age group which is affected is more than 50.
Okay, thank you. And Dr. Uday Shankar, uh, what should someone do immediately if they suspects a person is having a stroke? So, because this a lot of time people are unaware of what to do, and as Professor Kameshwar Prasad pointed out, these are the signs and symptoms that happen. He mentioned about be fast. So we have to act fast also, because there's a theme. This every minute counts, and act fast is a theme for Stroke Day of 2025. So, in your opinion, what should someone do immediately if they suspect a person is having a stroke? Because a lot of time bystanders, they see it. So whether it's a bystander, whether it's a relative, so what should they do?
As Sir has mentioned, immediate recognition, accurate recognition is very important, but a lay person may or may not identify it. So if an individual who has this complaint, or if somebody notices these complaints, it is important that that person is examined or evaluated as a person who is going to become unconscious or who may fall down, like airway, breathing, circulation, these common parameters which we check. And we have to stabilize the patient. We have to make sure that he does not hurt himself. We have to check the vitals, and you have to summon emergency help. You have to inform the emergency very quickly, and also you should try to find out when was the last time patient was absolutely normal. It's a very important time to factor to plan further treatment. Last known well time, LKW time. And once we do that, once the information is in place, the patient should be transported to a stroke ready hospital for further management.
Thank you. So I'll just come over to back to Dr. Vivek, because he's in a hospital at Fortis Mohali, and which has one of the highest, when you look at our network of hospitals, as far as treating stroke patients are concerned, and which is one of the few hospitals which has a biplane cath lab to do all the complex neurointerventions. They have a team of neurologists, neurosurgeons. So what I'm asking is that what are the modern treatments available for stroke? You know, as was rightly pointed out by Dr. Prasad, that all our Fortis hospitals are stroke ready. So what are the modern treatments available for stroke at Fortis hospitals?
So this is very important so that it can percolate. So from ages, there was only a single drug which was being given, and the major drawback for that drug was the time, because the effect of that drug was very less after 4.5 hours. Since 2015, now we have guidelines for a modern treatment, as you were asking, which is called mechanical thrombectomy. So, as the name suggests, it's a process where we mechanically remove the clot within the brain. And it makes sense because if there is a block somewhere, and if you can mechanically remove it without relying on drugs, whether they act or not, so it makes perfect common sense. So this treatment, mechanical thrombectomy, we need not open the brain. We can go through our wrist or into the blood vessels through our wrist or through our groin. A very small hole is made, and we can go right inside the brain wherever the block is. Earlier, this treatment was only for large vessel occlusions. That means only the bigger vessels are amenable for this treatment. But as our understanding of the disease and as our hardware has grown better over last 10, 15 years, now we can go even to smaller vessels if need be, and we can remove. So for the public, what I want to percolate is that at the moment, the most latest treatment for the acute stroke is mechanical thrombectomy. And the good thing about this is that it can be offered to select patients even till 24 hours, which gives us a very wide berth for treatment. Earlier, the major limitation was that patient did not reach well in time for the IV thrombolysis or the medical treatment. But with this extended window, now we can offer this treatment at least to some of the patients even till 24 hours or even beyond 24 hours as the guidelines are still coming in. So mechanical thrombectomy is the most advanced thing which has happened now.
Okay, thank you. Just coming to Dr. Prasad, sir. In your opinion, if you could just give us an outline, because there's a thrombotic stroke, which is from the clot, there's a hemorrhagic stroke, and they have different lines of treatment. But for both the varieties that are there, thrombotic as well as hemorrhagic, what are the standard guidelines that are nationally followed, and we in general in Fortis also adhere to that? Like we talk about the 4.5 hours, sometimes we can extended period, we can go and also do thrombolysis, or if not required, as Vivek correctly mentioned, mechanical thrombectomy. So just an overview of that, so which will give the public also a right way of how to take care of stroke.
Yeah, actually, two major lines of treatment. One is dissolving the clot, which is we call thrombolysis, and second, removing the clot, which we call thrombectomy. That is for both for ischemic stroke. For laymen, I call this blockage type of stroke. And of course, the other type, which is leakage type of stroke, in which blood leaks out of the blood vessels, there is a very different line of management. But for thrombolysis or thrombectomy, internationally, 4.5 hours, initial 4.5 hours is agreed upon by almost all guidelines for thrombolysis. In thrombolysis, we have two options, L-teplase or tenecteplase, and both are supposed to be equally effective. Though I must say that US FDA has so far approved use of L-teplase only up to 3 hours, and therefore 3.5 hours is something because it is based on international guidelines. Now, what Chinese have done is, Chinese are doing right, left, and center so many trials that even for thrombolysis, they have extended and published papers that it may work even up to 24 hours if there is salvageable penumbra. So the question is, do we have salvageable brain for protecting, or let's say for neuroprotection or not? So that is where we need a special type of equipment, and fortunately, we have it in Vasant. I am sure they have it in Mohali. Perhaps all Fortis hospitals, stroke ready hospitals will have it, where we can do diffusion perfusion mismatch. We can identify how much of their ischemic penumbra is present, so it can be saved. So if this type of imaging is available, no problem in extending the window for thrombolysis up to 9 hours. And now, if Chinese trial is confirmed in another, at least one more trial, then I think it can be extended even up to 24 hours, even for thrombolysis, not only thrombectomy, even for thrombolysis. So, but that works only if there is no facility for thrombectomy. So if thrombectomy facility is not there, which is true in many peripheral hospitals, then one can use thrombolysis even up to 24 hours if there is perfusion-diffusion mismatch. But I caution that beyond 9 hours, guidelines have not yet adopted 24 hours. That is the Chinese trial, needs to be confirmed in another trial, perhaps where there is no thrombectomy, because once thrombectomy is there, then timeless trial showed that thrombolysis doesn't contribute at all in terms of efficacy. So that is about the thrombolysis. About thrombectomy, certainly now there is no debate that up to 6 hours thrombectomy can be done in any patient, even if you don't need even perfusion-diffusion mismatch. you can straight away find large artery occlusion, do thrombectomy. But beyond 6, which means up to 24 hours, you have to show that yes, there is salvageable penumbra. Again, you need some facility, either CT based or MRI based, to show perfusion diffusion mismatch. If there is at least 20% of the at risk tissue which is salvageable, you can perhaps do thrombectomy up to 24 hours. That much, that guideline has been adopted perhaps all around the world. But thrombectomy, it is not yet adopted for 24 hours. But Chinese trial has shown benefit when there is no thrombectomy. Perhaps one more trial is required before it will be accepted throughout the world, that we can extend thrombolysis time window up to 24 hours. So that is the situation as far as I know. But things are changing, and as I told you that some more trials are coming, and hopefully in short time we will have news which is good for patients with stroke and people who treat stroke. Thank you.
Thank you, sir. And first of all, we'd like to be happy that Fortis all our hospitals are stroke ready, right from the ER to the having good radiology functions, neurologists, neurointervention, neurosurgeons. And Dr. Prasad has rightly given an overview of the treatment modalities. There is still a segment of patients who may require surgery. So this is where I come on to our neurosurgeon here, Dr. Vijay Kumar. Which are the cases where surgery is required, or they require surgical monitoring by the neurosurgeons till we know that no neurosurgical intervention is required? Because it's a very gray area. Sometimes one has to be very cautious about this. So it's important that the public is aware, and as Dr. Prasad rightly mentioned, the referring physician is also aware of it. Over to you, Dr. Vijay.
Sure. Thank you, sir. I think that's a wonderful question in the sense that that emphasizes one other thing which is very important in stroke management of stroke patients, which is teamwork. And I think when we say Fortis Hospitals stroke ready, it also implies that we have a team in place. So the team comprises of a whole lot of people, from the ER physicians who sort of activate the code fast, to the neurologists who are on call around the clock, the neurointerventionists who are available, and the neurosurgeons who are also available. So does every stroke need a neurosurgeon to be available or neurosurgical intervention to be available? And the answer is yes, because any stroke, number one, despite appropriate management, can extend or can get worse with time. So that is number one. Number two, strokes, particularly with the modern treatments that are given, thrombolysis or thrombectomy, a small incidence of hemorrhagic conversion in the area of stroke brain is always a possibility. Now, anytime there is mass effect on surrounding normal brain, to the extent that we can see that the ICP, as we say, the intracranial pressure is rising, or the conscious level of the patient is deteriorating, the possibility of surgical intervention is always there. So what are the interventions that we do in sort of ischemic strokes? We just try and create a little bit of extra space for the ischemic or infarcted brain to be able to swell. So one of the more common procedures that we do is what is called a decompressive craniectomy, which is basically just taking out a piece of the skull. The size would depend on how much extra volume we are trying to achieve or accommodate. But usually we kind of do a slightly large flap of bone and expand the dura also, which is called an expansile duroplasty. By this procedure, we just allow the infarcted or the stroke brain to swell which almost all injured tissues will do. Yeah? So this is one sort of thing in a routine ischemic stroke. In hemorrhagic strokes, or where there is a hemorrhagic conversion secondarily in an ischemic stroke, in addition to creating an extra space, we may also use various devices or techniques to remove the blood that has gone into the brain. So sometimes we do this endoscopically, sometimes we do this with navigation guidance, and sometimes we just do this with kind of standard neurosurgical techniques. So this is in the terms of, the elderly stroke that we are discussing. Then, of course, there is a whole other class of stroke, which is not this sort of classical thing, which we anyway think of as surgical stroke. So these are patients who have had intracranial aneurysms or who have arteriovenous malformations. Then, of course, there's again, a lot of teamwork involved in terms of trying to decide how is the patient best managed. Because a lot of what we used to do traditionally in the past have been taken over by my colleagues here, Dr. Vivek, and so they kind of do a lot of the stuff that we would do in the past. So almost no or very few aneurysms get clipped nowadays. I think they all get interventional radiology and coiling done. And if I were a patient, often I would prefer that too, rather than a big sort of invasive surgery. So those are another kind of situation. And then lastly, where you have arteriovenous malformations, again, there is a lot of scope for teamwork because, there are a variety of ways in which we can treat them with surgery, with interventional radiology, even with gamma knife. Yeah. So those are the kind of areas in which surgery is helpful. And lastly, of course, there is a big player in all of this, which is also the intensive care specialist. Yeah. So because in all of the stroke management, they also play a very important role in getting our patients through the acute phase of illness and getting them on the road to wellness.
Thank you, Dr. Vijay. Coming to Dr. Rajeev, is that how long does recovery usually take after a stroke? Because this is something that people should be aware of.
Yeah, absolutely, and it's very important for us treating doctors also to counsel them appropriately. As has been mentioned by Dr. Vivek also earlier, uh, in our armamentarium, we have, for example, we have right from conserving, which is doing just medical management, or IV lysis, or mechanical thrombectomy, or maybe surgical decompression. The entire answer to this question depends on when has the patient come to us. So recovery is decided on how much of the brain has been damaged, how long has it been damaged for, did we salvage that salvageable penumbra if the patient has come on time, and were there any complications during the course of his disease treatment which could affect his recovery? So it's very difficult to give every like a generic response to every patient about stroke. But what we like telling patients who come within a certain window period is firstly that we have moved away from this concept of the chronological clock, and we have moved towards the biological clock, which means that there could be a patient, like recently I had an 86-year-old lady, she was 86. Now that's a time that we do not expect them to have great collaterals. But she came to us with a wake-up stroke and she had lovely collaterals. And despite a large vessel occlusion at the level of a M1 segment of a MCA, we took her for intervention. We pulled out the offending clot, and she was out of the hospital with weakness, uh, and it took her about 7 to 8 days. On the other hand, we have had what we call as a subset called rapid progressors, which could be at even a younger age of say 40. And this rapid progressors could deteriorate and have a huge infarct without any salvageable penumbra, in which probably decompression is the only solution, and they will have a more prolonged course. So the mantra that we should use, I think, for the lay public, what I like telling them is that every second counts, every minute counts. The faster that you come to a stroke ready center, like we were mentioning, all our Fortis centers are stroke ready. The faster you reach such a stroke ready center, the greater are your chances of good recovery. And when we talk about recovery, all the trials will talk about an MRS, that is a modified Rankin score at 3 months. That's because even if you have two patients, patient A has had treatment for the same disease and patient B has had no treatment, though he was in the window period for the same disease, the outcome at 3 months will be much better for patient A than patient B. So I think this question of outcome is something which is very important to be explained and understood, that the faster you come, the better will be your outcome.
Okay, thank you, Rajeev. And Dr. Uday,
Can I add something, Dr. Vishnu? Can I add
yes,
something?
sure, sir.
Basically, when I keep telling this to my junior doctor, that when you are seeing the patient for the first time and patient has reached within hours, maybe certainly within first few hours, first thing we tell them is that our main goal is to stop deterioration and save as much brain as possible. That is the thing. They will say, Dr. Saab, will he recover? No, we are not talking of recovery right now. We are at this time engaged in saving as much brain as possible and also protecting or preventing any deterioration which may be life threatening. So that is, we are trying to save life, we are trying to save brain. That is the first few days, that is the exercise. When the patient has stabilized, and then the phase comes when some people will recover very fast, because with thrombectomy, you must have patients should know that sometimes within 24 hours they are up and about, because their limbs are saved, they can walk, they can use upper limbs. But those who are still bed bound, there the main thing is to prevent complications, so that risk to life because of complications is saved. I tell them that I will talk about recovery only when patient is getting discharged. If patient is getting discharged and is in good condition, then of course they know that patient has recovered so well and will recover very fast. But those who have not recovered, I tell them that you keep a time scale of months, not days or weeks. It may take 3 months, it may take 6 months. 3 months, almost 70% of recovery will take place. And up to 6 months, whatever recovery has to take place, 90% would be over. Beyond 3 months, some recovery does take place, but it takes years, sometimes up to 2 years. So that is the way I ask my junior doctors to counsel the patients. That is the timeline.
Very useful information. Dr. Uday, what lifestyle changes can help reduce the risk of stroke?
Very pertinent question. Stroke can also be considered as a very typical lifestyle disease. There are some eminently intervenable factors which can be modified here to prevent stroke. The strongest evidence comes from proper treatment of hypertension, aggressive treatment of hypertension, aggressive reduction in cholesterol, avoiding obesity, avoiding sedentary lifestyle, stopping smoking, avoiding excess of alcohol consumption, and avoiding exposure to certain psychoactive or other illicit substances, These are the common, very high yield tactics to bring down the incidence of stroke. And this should be coupled with methods to improve healthy lifestyle, like methods to promote weight loss, methods to have healthy nutritious diet. For example, like high fiber, green leafy vegetables, the so-called, we call it as Mediterranean diet, where you have unsaturated fatty acids and where you have higher amount of intake of legumes, pulses, nuts, and an adequate amount of exercise, aerobic exercise, let's say about 150 minutes of brisk walking divided over 5 to 6 days in a week. These are some of the easily attainable high yield tactics which can reduce the incidence of stroke in all age groups.
Okay, thank you. Dr. Vivek, would like to ask is that are stroke symptoms different in women compared to men, or there is no difference between either sex?
Very interesting question, Dr. Panigrahi. So traditionally, the stroke symptoms, which our colleagues have already mentioned, can be said as FAST, right? But in female, there are some features which might be seen, which are not seen as commonly in males. So those symptoms are more or less vague symptoms like sudden onset of fatigue or confusion, or sometimes vertigo, in layman terms, chakarana, sometimes profuse sweating. So these two symptoms, which do not right away point towards the brain, are seen more frequently in females. But having said that, it does not mean that these symptoms will never be seen in males. But yes, when we see the frequency of the symptoms, apart from the traditional symptoms of sudden loss of speech, eyes, paralysis, these symptoms of breathlessness or becoming confused or loss of consciousness are seen more in females. So this is the basic difference between the traditional symptoms and the symptoms which are seen sometimes more in female population.
Uh, Thank you. Just coming to Dr. Prasad, whom I'll say that he's the pitama of stroke for Fortis Healthcare. We take a lot of insights from him, and he was there when FICCI had organized the meeting with the World Stroke Organization. He was a major speaker there, and something which came to light was I also was not aware of it. Was just told by the president of the World Stroke Association that during the pandemics, that the recent pandemic that happened during COVID, more people died of stroke than from COVID. So in the WHO, this was discussed, and there was, on the lighter side, they were joking that should stroke be declared as a pandemic. So what is coming out is that across the globe, stroke is hitting us in a big way. India is no outlier there. So my request to Dr. Prasad is that we as a healthcare provider should start looking at prevention also, which we are putting a major effort now across our network of hospitals on the preventive aspects of healthcare. Curative everyone is doing, but I think so preventive part is something that we need to focus on. The government of India is also very keen that. So, in your opinion, sir, what are the take-home messages that we can disseminate? Is that what are the things that we need to do to say that stroke is also preventable?
Yeah, I think most people, they are aware of lifestyle factors, and we have emphasized this again and again. And I always tell them, in those who are Hindi speaking, that you take care of Khan, Pan, Ayam, and Vyayam, right? Khan, Pan, everybody understands eating, drinking. And in Hindi, fortunately, Pan, Pina goes along with cigarette Pina also and Bidi Pina also. So Pina includes smoking in a very a good way in Hindi. So already Khan has been explained. Pan, whether it is excessive alcohol or it is smoking, or use of tobacco in general. So that part has to be emphasized. Then we say I am in Hindi, in English means dimension. Your dimension, your waist circumference, your waist hip ratio, your body mass index. So if you keep that in check, that is another very important exercise for prevention. And then Vyayam, which is physical activity. And we often emphasize that every week, at least 30 minutes of brisk walking for 5 days in a week. That is what may be good enough, at least from preventive aspect. But these are four things which we talk about in lifestyle. We have to also talk about four conditions. So 4+4, that is how we emphasize this. And the four conditions are high cholesterol, high blood pressure, high blood sugar, and heart disease. I always say that heart disease is something which is an enemy for brain, and it can cause stroke, particularly atrial fibrillation in old age, or for that matter, rheumatic heart disease in young people as well. So if we keep 4+4, we are left with minor risk factors like obstructive sleep apnea, that is also a risk factor. Sickle cell disease is a risk factor. So those things are not as widely prevalent as we are talking about in public health viewpoint. Hypertension, high blood pressure, high blood sugar, high blood cholesterol, heart disease, and four things which we talked about in lifestyle, where we included weight also. So high BMI is another thing which we have to keep in mind. So if we control all these, it is estimated that we would be able to prevent at least 50% of strokes. That is from the known risk factors. Still, some papers would say that 80%, but I think that is an overestimate. At least 50% will be able to prevent if we take care of 4+4.
Thank you, sir. We have some interesting questions. So I'll read out one by one, and I'll leave it to the panelists that you can answer whichever way you want it. So I'll start off with one. Suraj Sharma has asked the question is that gone off. Sorry, Shivangi Thakur. Suraj, your question has gone off. Anyway, coming to Mithilesh Pandey, have read somewhere that woman is prone to migraine and men most like to get stroke. Is it true? It is something to with Vivek that mentioned. So, Doctor, I'll leave it to anyone just to answer Mithilesh's question about women prone to migraine and men most likely to get stroke. Is it true?
Well, maybe I should answer this briefly. Others can also add to what I say. It is true that migraine is more prevalent in women than in men, which means if out of 100 women, there will be 20 to 25 who will have migraine, whereas males, maybe 15 will have migraine. So that way, women are at higher risk of having migraine. When it comes to stroke, that difference is not so much. But yes, if you see gender or sex as a risk factor, then being male, having a male gender is a risk factor, which means males are more prone to getting stroke than females. But the difference is not as much as we talked about in migraine. It will be something like if the one male is getting stroke out of, let's say, 100, there will be 100 is, I think, not a good number. 1,000 out of 1,000, if 10 people are getting stroke in males, there will be 7 who will get in females. But when they achieve menopause, after menopause, the risk becomes almost similar. So post-menopausal risk in male and female becomes similar. So that statement has some, you can say, truth in it, but it's not black and white. That migraine is for females, stroke is for males.
There's another
I
question
may
from
add,
Amit Mukherjee. Sorry.
I may add one point,
Yeah,
if
sure.
I may.
Please go ahead.
In women with a very severe history of migraine, especially in the third or fourth decade of life, if they're exposed to medicines like oral contraceptives, they have a high risk of stroke happening. So that is one particular uh, preventive or precaution aspect which we have to take precaution when we prescribe medicines. It's an important point. Yes.
Amit Mukherjee, he has asked a question: if someone in my family has had a stroke, what extra precautions should I take? Uday, over to you.
Um, I think the other speakers have made it very clear. It's very clear that there are multiple risk factors involved, and there are multiple overlapping risk factors which affect our vascular tree. And most of these conditions have what are called multifactorial inheritance. That means there are factors, genetic factors, which occur at various levels of effectiveness. So that means it is a person with a history of stroke may have certain other person, certain individual who may have had stroke because of overlapping of these factors. The suggestion is to look for all the risk factors for stroke, which we have all of us have discussed already, identify it and treat it aggressively, and take care of the lifestyle. That is my sincere advice.
The last question has come from Mohammed Usman. Sir, what should be the first response after detection of early symptoms of stroke before emergency medical services arrive, and what should be the window? Dr. Vijay?
I think the most important things are, to first of all keep the patient comfortable. So to loosen any tight clothing, make sure that he's in a well ventilated, airy room, and maybe get him to lie down, particularly if he's feeling dizzy or giddy. If they sort of start losing consciousness, or if they start having a fit, then put them on the side. Make sure that the tongue doesn't fall back, or they don't aspirate secretions. That is the first aid measures that any lay person can do. But I think we've all emphasized that speed is of the essence, and we need to get him as quickly and as early as possible to a stroke ready facility. Yeah.
Thank you.
Yeah,
Go ahead, please.
just a small point I just wish to add is that as a first response, what we should be telling people is that the first response should be to call an ambulance. Apart from whatever my colleague has said, the first
Yeah.
response should be to call an ambulance. And what equally important is what not to do. We should not be giving any water, food, or any kind of medication, because we commonly hear that we have given blood thinners, aspirin, or something. We felt it's a stroke, which could be very, very disastrous for the patient. So the message which I want to put across is, after calling the ambulance, make the patient comfortable, ensure that he does not fall, and don't give anything by orally or by mouth.
Thanks,
Another
Rajeev.
point, if I may add,
Yeah, sure,
most
sir.
of these patients have history of diabetes mellitus. So I think we should potentially check for possibility of hypoglycemia. The glucometers will be there. By the time you call the ambulance, by the time it comes, you check the blood sugar, see what is happening, make a note of it. Because some of the hypoglycemia symptoms can also mimic stroke. And if it is not recognized, it can have serious consequences.
Right.
Thank you. I think so. Our time is up because we are nearly. It was a very enriching experience to hear everyone. And I was, on behalf of Fortis Healthcare, I want to thank all the panelists for their expert opinion, and the public at large who are hearing this, seeing this. And I think so. The theme this year of the World Stroke Day is very important, very apt. Every minute counts. We need to act fast. And I think so. Dr. Kameshwar Prasad summed it up very well. Be fast. So I think so. With that, I'd like to say thank you and namaskar to everyone.
Thank you.
Thank you.
Thank you.
Thank you very much for organizing this.